Good day, ladies and gentlemen. We would be talking about left atrial function in heart failure today. The left atrium is the most posterior cardiac chamber connected to the left ventricle and separated from the right atrium by interatrial septum. It is anchored to the pulmonary veins, and the major determinant of left atrial expansion is systolic contraction with downward displacement of the LV base towards the apex. There are four main functions of the left atrium. It is a dynamic blood transporter. It is a neuroendocrine organ releasing atrial natriuretic peptides. It is involved in reflex control of the heart rate and blood pressure, and it is involved with atrioventricular synchrony. However, we need to keep in mind the left atrium is not a symmetrically shaped 3D structure, and hence geometric assumptions by 2D in measuring left atrial volume are not accurate completely and reliable. Why do we want to measure left atrial function in heart failure? Because it provides better window to heart failure with regard to diagnosis, etiology, and prognosis. There are three main components of left atrial function as far as the volume dispelling is concerned: reservoir function during ventricular systole, conduit function during early diastole, and pump function during end diastole. Nowadays, dedicated software for LA quantification are available, which are able to give us idea about left atrial volume, maximum, minimum, left atrial emptying fraction, conduit function, booster function, so on and so forth, making our job easier. Earlier, we had to do a lot of these things manually, and that was one of the reasons why LA quantification was not performed in routine clinical practice. Normal left atrial contribution to filling the reservoir function contributes 40%, conduit function 35%, and pump function 25%. Remember, with aging, pump function goes up and could be as much as 40%. The gold standard for assessing left atrial function is a pressure volume loop, which has two components, atrial loop and ventricular loop. However, we have got surrogates for the left atrial pressure volume loop, which I'll be discussing with you. There is also this law of constant volume pump for the whole heart, which says that the volume of the left ventricle and left atrium in systole and diastole is constant, and that means there is a reciprocal relationship between the volume. However, now we realize that the reciprocal relationship may not be there as far as the functions are concerned. So how does atrial remodeling takes place in heart failure? There is atrial dilatation and atrial mechanical failure. Both parameters impact prognosis. Hemodynamic definition of heart failure is elevated filling pressures and demand-related reduced cardiac output. Both situations, the left atrium plays a big role. So the left atrial function is a barometer of following parameters in heart failure: left ventricle filling pressure, rhythm, especially atrial fibrillation, pulmonary vascular disease, VO2 max and exercise capacity, the prediction, occurrence of MR, and of course severity of mitral regurgitation. No single parameter best defines left atrial function. However, the usual left atrial function parameters that we study are LA diameter, LA volume index, LA reservoir strain, left atrial coupling index, left atrial stiffness, and of course tissue Doppler A prime, which is again a marker of left atrial function, and left atrial compliance, which is nothing but a maximum volume minus minimum volume divided by minimum volume and multiplied by 100. The reference values are shown here, and we will be discussing the reference values subsequently as well. But when we talk of left atrial volume, keep in mind one thing, that we need to measure if we are using 2D, we have to measure the left atrial volume in focus views, LA focus views, which are usually little medial and posterior to the standard apical 4-chamber, 2-chamber views, because the long axis of left ventricle and long axis of left atrium are not in the same line, and they're usually an obtuse angle of 150 degrees. So although we commonly use 2D to get left atrial volumes, but we need to keep in mind that there is usually left atrial foreshortening in 2D echo. The geometric assumption may not be valid, and of course manual tracing itself has certain issues. 3D is a much better technique than 2D because it provides us more accurate volumes, more robust, comparable to cardiac MR and CT, and of course we can find out volume in various phases of cardiac cycle. and better understand the left atrial function. The Luigi Badano and colleagues actually have recently studied the left atrial volume index and left atrial function in healthy individuals, and they have given the 3D upper reference limit of 43 ml per meter square, 2D 35 ml per meter square, regardless of gender, clearly telling us that the volumes are higher by 3D, even though 3D volumes are slightly lower than that derived by cardiac MR. Left atrial volume correlates with survival in population-based study from Olmsted County. As the left atrial volume index increases, the event-free survival decreases. The same thing is very much true in patients of heart failure as well. So, and not only that, the incident heart failure or new onset heart failure is also related to the baseline left atrial volume index. Again, the data from Olmsted County in elderly individuals states that as the left atrial volume shown on the left side increases, the new onset heart failure increases, and by a difference of 9 ml per meter square, the 3 times higher new onset heart failures occur. Left atrial compliance, as I already said, is a difference between the left atrial maximum volume minus the minimum volume divided by minimum volume multiplied by 100. Normally it is about 200%. It correlates with the exercise capacity and hence is a good parameter of heart failure symptoms and also prognosis. Data also suggests from Olmsted County of 2,000 individuals that left atrial volume index measured by 2D and the both 4-chamber and 2-chamber combined biplane correlates with the grade of diastolic dysfunction. As you move from normal to grade 1, grade 2 and grade 3 diastolic dysfunction, the left atrial volume progressively increases. So there is a relationship between left atrial volume and diastolic dysfunction. It tells you about severity and chronicity of diastolic dysfunction. What about transthoracic Doppler method for LA function? The A wave, whether transmitral flow A wave or tissue Doppler A wave, both relate to the left atrial function. Better preserved is the A wave, better is the left atrial function. Typically, the tissue A prime should be more than 5 centimeters per second in healthy individuals. It usually is around 8, 9, 10 centimeters per second. Shown here is an example of a 60 years male with 25% ejection fraction class 2 dyspnea and A prime laterally about 10 centimeters per second. This kind of information says that the patient has a relatively good left atrial function and better prognosis. Why better prognosis? Because the data suggests that those people who have mitral annulus A prime less than 5 centimeter have a poorer event-free survival compared to those who have an A prime more than 5 centimeter on follow-up. What about deformation imaging in left atrium? It is also a good tool for function. 3 types of deformation or strains are studied. Reservoir strain, or also called peak atrial longitudinal strain, conduit strain, and booster strain. Currently, most of the data in heart failure has been validated with reservoir strain. There are definite ways of obtaining reservoir strain. It should be done in both 4 and 2 chamber views. The both should be LA focused view, and you have to average this. And of course, there is a standard methodology given by European Society of Cardiovascular Imaging, which needs to be followed. Normal left atrial reservoir strain in this meta-analysis of 68,000 individuals is in the ballpark of 40%, 38 plus minus 3, the lowest limit being 32, and of course it correlates with the left atrial volume index of 24 plus minus 6 ml. At the same time, there is no dependency of the reservoir strain on left atrial volume, and hence it provides independent prognostic information. Left atrial reservoir strain also correlates with left atrial fibrosis, as shown in this picture. From a 40 to 45% normal strain, as the strain goes down actually, and it starts going down below 30%, left atrial posterior fibrosis can be detected by cardiac MR. Left atrial reservoir strain also correlates with the filling pressures. His data to suggest close correlation, negative correlation between global left atrial strain and pulmonary capillary wedge pressure. Left atrial global longitudinal strain, or the pulse or the reservoir strain, is a strong prognostic factor in HFrEF patients independent of left ventricular global longitudinal strain and left atrial volume index. In this study of over 400 patients followed for 2.5 years, a peak atrial longitudinal strain of more than 18.6% had a relatively better prognosis, and as you went down to the last tertile, prognosis was worse. So between the first tertile and last tertile, there is nearly 7 times difference with regard to event-free survival, clearly showing that independent prognostic significance of LA reservoir strain is there. Another parameter which has been proposed by the Mayo Clinic just 2 weeks back is called left atrial coupling index. It is nothing but a ratio of left atrial volume index to A prime of the medial annulus. Typically, it value less than 6. More than 6 portends worse prognosis in heart failure. And this has been shown in this study of nearly 4,002 patients. And the prognosis is almost 100% worse in those who have left atrial coupling index of 6 or more. Left atrial stiffness index is another parameter which has been suggested in heart failure patients. It is a ratio of E to E prime to peak atrial longitudinal strain. Typically, it will be 0.3, as I already said, but if the value is more than 0.76, it has a great sensitivity and specificity in detecting future cardiovascular death and hospitalization for heart failure. Of course, atrial longitudinal reservoir strain alone is also capable of giving that information, but slightly inferior to this left atrial stiffness index. And here is an example of a 65-year gentleman with hypertension and dyspnea. Left atrial reservoir strain 19%, but the E2 prime 7.4. So the left atrial stiffness index is 0.4. Obviously, this patient would have a good prognosis. The left atrial reservoir strain also helps in detecting isolated atrial disease, maybe atrial cardiomyopathy. Here is a hypertensive individual actually who has a very good LV global longitudinal strain of minus 24%, but the LA strain is plus 20, indicating that some diseases can isolate or dominantly affect the left atrium. It could be hypertension, diabetes, amyloidosis, restrictive cardiomyopathy, and so on. Here is a classic example. What is the significance of studying the left atrial volume or left atrial remodeling? Well, the reverse remodeling is possible with drugs. This is the PROVE-HF data showing that the left atrial volume progressively goes down from baseline to 6 months to 1 year as ARNI is being given to these 794 individuals with HFrEF. James Januzzi's study, it clearly says that the left atrial volume does come down with effective therapy, and hence it is a useful, clinically useful parameter of reverse remodeling. So, ladies and gentlemen, to summarize, it is important to study left atrial function in heart failure. There is no single parameter that best defines left atrial function, but I suggest a combination of 3 parameters: left atrial volume index, ideally by 3D, if not by 2D, biplane area length or Simpson method, studying the left atrial reservoir strain, and of course A prime by tissue Doppler. All these 3 things should be individually mentioned, and if 2 of these 3 are grossly abnormal, left atrial dysfunction is present. If all 3, definitely there is left atrial dysfunction. With these ways, we can better discriminate the prognosis of our patients with heart failure, and also we can study how these people behave when medicines are given to these individuals. In case these parameters improve, there is obviously reverse remodeling of the left atrium, and patient is going to be better in future. Thank you very much.